All right, kids, you are watching or listening to Wake Up Call the podcast, and I am your host, Christina Previtt, and this is a special edition of the hashtag Fem Doctor series, my new series. And my guest today is Dr. Rashmi Advani MD, who is a gastroenterologist in New York. Welcome, Rashmi, or
Hi.
I should say Dr. Advani, because you
No,
worked
no.
that.
Yeah, call me Rashmi. I mean, I love how you actually you pronounce my name just perfectly. Yeah, I am a GI fellow in New York. So I'm currently still in my training of 3 years. I'm in my second year of the 3-year general training. And yeah, thank you so much for inviting me to be on your amazing podcast series. I think this initiative is really, really cool and I totally support it.
Thank you. I appreciate that so much. And I think I forgot to mention that the way I found you was on Instagram, and you have a really cool handle, Dr. Scopes with Guts. DR Scopes with Guts. So everybody should really check you out because you're very prolific on Instagram with your videos.
I appreciate that. I mean, I've definitely taken a lot of like advice and like inspiration from other platforms and other people, and I just try to create my own thing and something to help educate my followers and connect with my community. And it's just a really fun way to just kind of get yourself out there and impact the community in more ways than outside of your clinic or outside of the endoscopy suite, it's pretty fun.
Yeah, what I like about it is like you and other people who are doing what you do on social media, it really personalizes you because I think in the past people would go to their doctor, but they might feel really intimidated in that setting. And I think when that happens, they're afraid to ask questions, which is not good, right? You have to understand what your treatment is. So that's what I like about you and other people that are so present on social media, is because you get a chance to kind of feel like you know the person a little bit, and they're a human being, not just a doctor. So I'm kind of liking what I'm seeing trending on social media.
Yeah, I actually didn't realize how many of us started coming up, like surfacing on the platform. I mean, we have Twitter, and I think Twitter can be pretty professional in some ways when it comes to like connecting with colleagues, but I don't think that there is a good translation between like physician to say patient or general public. I think it can be very close knit and very niche based. But I think like platforms like Instagram and TikTok. I'm sure there are positives and negatives to everything, obviously, but those platforms have not only like increased people's awareness of like certain diseases, certain things that they should be thinking about, how things that they otherwise like maybe might not have time to ask or don't remember to ask during their visit with their doctor, or something that we also neglect to not really address. And I think on this is a way for us to kind of open those gates of communication like you mentioned. And personally, I mean, like I've had similar experiences growing up with my adult physician that I used to go to, and I felt like those less than 5 minutes that I was spent in the room, I just didn't have a chance to really have all my concerns heard or my feelings addressed. And I get it, like looking on the other side of the coin and seeing what the time constraints that all of us have, and all of us are pressured, especially with electronic documentation. I mean, I can go into all of it, but um I think the Instagram and TikTok platforms have beautifully been able to at least open that type of communication between patients and providers. And I mean, some providers might be also looking for prospective patients or people that they think that they can help, and cast a wider net. And the community is large, so definitely, I definitely see more positive than negative on social media.
Yeah, definitely. I mean, I think it is definitely also the younger crowd that is probably the incoming breed is on more evident on social media than the older crowd. I don't know how to politely say that, but there it is. And it's not a criticism. It's just different. It's just a different way of life. It's like, little kids now. I have a goddaughter who's 7. She doesn't ever know what life was like without an iPad or an iPhone. And I still have trouble sometimes using my iPhone, and I just hand it to her, and at the age of 7, she really can figure it out pretty quickly. So it's generational.
I definitely agree. I mean, even in like the generation that we grew up with, the cell phones came out, and then internet went from dial up to actual like.
Yes.
So I think even in so many ways, us as like a as the millennial generation, I'm constantly learning from my nieces and nephews, because they have figured it all out way in advance than I would be able to. So I don't feel bad about it at all, actually. I think it's actually quite awesome that, like, we've progressed so much to this point in society where we have those types of tools available to us. So
Well, I hope that it ultimately helps the community learn more about their health and how to take care of themselves, and ultimately makes them feel more comfortable asking questions when they do go to the doctor, because even I feel a little intimidated at times, and I'm a big fancy lawyer, and there are times when I feel like, oh gosh, I really want to ask this question, but it's kind of a dumb question, and you might just sort of assume what the answer is but be wrong. So I have to take my own advice there too.
I mean, you'd be surprised, actually. I mean, even as doctors ourselves, like, we feel the same way when we go to our doctor's visits, because we're just like, should we know the answer to this question that we're currently asking? And I think, in a lot of ways, we have to, um, be comfortable with not knowing. And even as a patient, even as a provider, I think the the whole old notion of like, oh my God, like, the doctor knows it all, and then they know what's best, and that
Yeah.
kind of authoritative, paternalistic, very like one-sided discussion really is not in fashion anymore, especially in medicine. I think the way medicine has like kind of turned almost 180 degrees, where there's more of an open communication between the doctor and the patient. And there's like, nothing's perfect in science, and this is something I speak to my patients about, my colleagues. And we always are constantly facing the challenge of what we're providing, the information that we're providing to patients. Like, is it the best information to give them, or is it based in something that we believe in, and it's properly vetted. And like, I'm sure you've seen on social media, there's a lot of different sides to the stories. There are people who aren't who have a deep mistrust in allopathic medicine, or vice versa. They have a mistrust for naturopathic or holistic medicine. And I think there are two sides to every story when it comes to something like that. But I definitely agree with you. I think that the gates of communication are definitely a lot wider than they were even like last year. I think there are a lot more doctors that I've seen become public on social media and promoting information that otherwise I feel like other people won't be able to benefit from if they weren't promoting such information.
Well, I mean, ultimately, if you don't feel comfortable talking to your doctor, or if you don't feel comfortable just saying, I don't know what you just said because you're using medical terminology, which, lawyers do too. I think sometimes you just don't realize that you're saying something in your language that maybe other people don't understand. Just, it's
100%.
okay to say you don't understand.
Yeah. We say it all the time as well. I mean, if there's something that we don't understand, we're just like, okay, can you repeat that in a different way? Or, I think patients should definitely not feel afraid or embarrassed or shy in asking whatever question. No question, really, like we also say this in medicine, but no question at all is stupid. There's no such thing as a stupid question.
So how do they teach you that in law school, or do they teach you, sorry, med school? How do they teach you that in med school to counsel if I'm using the right terminology, counsel a patient? Do you learn that in med school, or is that something you really learn later?
So it's a little bit of both. So medical school, depending on how your medical school is structured, especially more recent, more up to date curriculums are focusing on that type of communication style and bond between the physician and the patient. Because if you create a trustful bond between your patient and yourself, then whatever conclusions or whatever treatment options or management decisions that you guys make, at least you both are on the same page. And if anything were to deviate off of that, like, you can always explore why. And because you had that relationship, that open relationship between you and your patient, that only helps you. But um, it, I think personally, when it came to my own training, we did have a couple courses, I think in third and fourth, like the later years of our medical school, where they did focus on more open communication style. But I think the bulk of that skill is learned in training. And I mean, there's also a little bit of like like your own personality when it comes to, because some people might have the best intentions and want to have their patient be as open as possible, but something in their demeanor, something in their approach to the situation, the patient doesn't feel comfortable expressing some concerns. And I think it's a little bit of, yeah, personality. It's a little bit of who you are and how you interact with not just patients but people in general. Like, are you
Mhm.
able to connect with people? you know
Yeah.
I think in
Yeah.
medicine, especially if you're going into that type of specialty, you're just it's not all about knowing medicine. It's not all about like knowing what's the best treatment or knowing what's the best management. You could be as brilliant as possible, do all the research in the world, but if you can't communicate well, effectively, then it kind of goes.
Yeah. I think that's often referred to as emotional intelligence. And I think you get better over time. At least I've experienced that over the course of my career. I'm certainly better at counseling somebody now than when I first started out, because I'm more confident about my knowledge and guiding somebody. And as you said, not just giving them specific legal information, but really counseling them on how this impacts their life. Because I imagine with medicine, it's not always about what drug I can give you, or what treatment is available, but it's more about, well, what is your preference and how is this actually going to impact your life on a daily basis?
Yeah, and I mean, it takes experience. It takes having a variety of patients who you talk to, having even maybe some experience outside of medicine. Me personally, I had some experience outside of medicine that actually I used to my advantage to help connect to my patients. And um I can't agree with you more. I mean, it's the terminology that you use should be very carefully executed. Meaning, like, whenever I try to describe a condition to the patient, I assume that they know nothing at all about anything about this particular disease process. So I use pictures, I use drawings, I you know use analogies. So I think that that kind of helps. And I I would expect that from a lawyer. Like, I don't know any legal terms at all. Like, but if I were to ask you, say, about like a specific situation or legal matter, I would expect you to, um approach me with the understanding that I know nothing at all about the topic.
Yeah. Speaking of, you mentioned your background, and I took the liberty of stalking you on LinkedIn as well, not just Instagram.
Okay.
And you do seem to have a varied background. And maybe what you could also do for me is I don't really understand what the usual trajectory is. So I don't really know, what is a resident, what is a fellow, can you sort of take me through that too?
Yeah, of course. And that's such a good question because I feel like even people in medicine, like unless you're pursuing a particular field or subspecialty, it's like you yourself don't even know how long or what stages are which. But anyway, so in order to apply to medical school, you have to complete a bachelor's or arts or sciences, and it could be really be in anything. Med schools actually prefer people who are not even science majors or minors.
Really? Oh,
Yeah,
I didn't know that. Do you
yeah.
have to have certain science requirements met though? Okay.
Yeah, you do have to do the basic classes like, chemistry, orgo, all the, the standard ones. But if you're like an arts major, philosophy major and stuff, and you have other interests, that's actually looked upon favorably. So, you have to complete college, and then medical school is usually 4 years. There are some accelerated programs that have come out in the recent years that are 3 years long. Um, which is insane. Actually, I don't know how,
Yeah.
but it's being done. And after that, then you choose a residency of your choice depending on your interest. So if most people either decide that they want to do something surgical or non-surgical, and the surgical side of the equation, there's several residencies, and they all range anywhere from like 3 years to 7 years or 8 years, and you're still a resident. You're called a resident. And the medical specialty, so you go into internal medicine, and then usually internal medicine is 3 years. I think the shortest residency is 3 years. um, and then after residency, if you are crazy enough, excuse me, and you want to go through extra training, and if you have a passion and everything about it, you can apply to something called a fellowship. And once you graduate residency, you can be a practicing attending in that, whatever residency you decided to do, like a dermatology or OB-GYN or something. But if you want to do a fellowship, then you go into the fellowship, and the fellowship can be anywhere from 1 year to 4 or 5 years. So, and then there are even sub fellowships after that. So it does go a little bit deep, and it could be very niche based, and it could be very very specific, like like a hand surgeon or someone who only works with like certain tendons or something. You can get very specialized people like that. But that's what a fellow is.
So it's not just an extension of a residency. It's specializing in something a little further than what you would have done just as a resident.
Exactly. I mean, like, so for example, so in GI, the only way to become a gastroenterologist is you have to go through a 3 year internal medicine residency, and then go into a 3 year fellowship of GI. And that's the way to get there. So, but otherwise, say if I didn't decide to do fellowship, I would be in a general medicine attending, or I'd be a primary care physician. And really, I mean, I think a lot of specialties, you can make what you want to make of it. Like you could work in the hospital, you could work in private, you could see patients like some days a week. So I think there's a lot of flexibility in that way. Um,
So for example, one of my favorite topics is plastic surgery. So that person would go into a surgical residency, and then they would have a fellowship for plastic surgery.
Pretty much. I mean, that's the traditional way into plastic surgery. There are more streamlined programs, and they're very far and few between and very competitive, but you can get into like a straight, plastic surgery route, but you definitely do need to still do your general surgery residency, and then go there. But the training is long, and say like if you wanted to do specifically for plastics, if you want to do something like face, or nose. I mean, that's an extra, like, you know, they call it like a sub fellowship or a sub fellowship. So, and that could take anywhere from 1 year to a couple years.
So do you have to, as an MD, do you have to do a residency? Is that a requirement?
In order to take care of patients, yes. To be a clinician, to do anything involving like direct contact of patient with you and a patient, yes.
Okay.
Yeah, but if
So
you,
you have your degree,
yeah.
but you wouldn't like what is the certification that you get to be able to treat patients? Do you have to get some additional
I mean,
certification?
I think you just have like a certification of completion of a training, and then you essentially take your board exams. So I think uh, so after your training, whatever, say residency or fellowship, you take a board exam, and that makes you board certified. So once you're board certified, you have, that extra, like, okay, this is what I do, this is my specialty kind of thing. But I've had colleagues who, after medical school, decided that they didn't want to go into which is a gamble, but they didn't want to go into residency, and they wanted to do something either in pharma, or some went to Wall Street, or some even went to the legal track, so or business. So I think there's like a lot of things that you can do with your MD, not just be a clinician.
So basically, if you don't ever do a residency, you just won't get a job because nobody would hire you, right? No.
Not as someone interacting with patients. Like, you can't, I mean, if you want to see patients and you want to take care of patients, and there's no other way around it, you have to go into some sort of residency. But if you do something that's non-clinical and like kind of more consulting and stuff, but you could definitely use your MD for that.
So when you're in med school, are you basically learning more like book work and, facts, and then you learn the actual how and the application when you get to the residency, or do you get a lot of that application when you're in medical school too?
It starts in medical school. It starts like midway through your medical school. Some of them actually integrate that a little bit more, especially in the last few years, where they realize that it's not like, yes, you can have all the book knowledge, but being able to apply all of it, like, should actually start earlier. So I like, even first and second year medical students are having clinical exposure to patients, and obviously in a very monitored setting, but yeah, it's built into medical school curriculum.
Okay.
Yeah.
I did always have a secret desire to take the class where you get to cut up the cadavers. I
And
know that sounds really morbid.
no, it doesn't. I mean, I think it's naturally for you to be curious about the structures of the human body, and I think that's you just take anatomy and physiology. I think if you just go and like enroll yourself into like maybe one of those college classes, I think you'd be able to do
But I
it.
don't get to cut up a body, right? I don't
Um,
think you get to do that.
Cadaver labs. I mean, it's probably unlikely. I think it's a lot of families are kind enough to donate like their loved one bodies and into the cadaver labs, and I think as a medical student, that's something that you have the opportunity to have exposure to. But actually, that's a good question. I don't know if college students can do cadaver labs. I don't think so. I
Is that
think
a requirement though in med school, or is there some way to avoid that, or do you have to do that?
I think you would have to. It's just like literally one of the core classes. And I mean, to be very fair, even as a first year medical student, and you know you're gung-ho about being a doctor and everything, there are people who will faint as soon as like
Really?
you know they see one of those dead bodies or they see a little blood or something, and it doesn't mean that they're not fit to be a doctor. It's just, you know, there are some responses, sympathetic and parasympathetic responses that our body elicits when we're like shocked about something or we're like excited about something. So
Did you see somebody faint in your class?
I saw someone close to fainting. Yeah. Yeah. I
Oh
definitely did.
man. Oh God. That
But
they probably never lived that down either. That's gotta be
you know what's actually ironic? That person ended up going into a surgical room
really.
and they're doing amazing. Their patients love them.
That is so funny. Are they all old people? The cadavers?
No, they range. It ranges, young, old, different genders. I don't we don't have pediatric um cadavers. I think just like morally probably doesn't sit very well,
Mhm.
but
Yeah.
yeah, but I think we have a bunch, most of us have like adult cadavers like in their like 40s, 50s, 60s, even 80s. And the structures are all the same. They all like look the same internal. We all look the same inside, by the way. Like it's just a bunch of pink and you know nerves and vessels and stuff.
I know. I'm just always curious. I don't know why it's like this perverse curiosity about, what it looks like in there.
I think you can YouTube it.
I do. I watch surgeries on YouTube. I mean, I kind of feel like I could do one, but I'm totally kidding there. Thank you for or indulging my perverse curiosity about that. I'm sure some other people that are in other professions have had some of the curiosity about that too. So you explained to us what residency is and what it means to be a fellow, but let's go through what you've done because it looks like you were an EMT at some point.
I was,
That's
yeah. So
cool.
it was well, I was in during my gap year, I completed college and I was like, you know, I kind of wanted to use this year to like do things that I really, really enjoyed. One of a few of the things involved, you know, teaching dance and still dancing and tutoring in English and math. But then the other part of me was like, I really need to start learning some medical terminology because if I don't know something, or I mean, I should know at least the basics, right? So I enrolled myself into some EMT classes, and it was the best decision I made. It just took a couple of months for us to get certified, and then you're back, you're on the field. So if you work in the ambulance, that's something like very high intensity, thinking on your feet kind of thing. And then if you work on the receiving end of a hospital, like you work with a particular hospital, particular service. Anyway, I used my curiosity in medicine to, you know, kind of segue myself into becoming an EMT kind of thing. And I think that actually, if anything, it only benefited me because when I got into medical school, I knew all these terms and I was like, okay, great. Like I'm not, at least I'm not starting from like complete scratch. There is some sort of knowledge up there.
Yeah, that's interesting that you felt like you needed to do that because a lot of people would just assume, well, I'm going to learn it when I go to medical school. But you wanted to be ahead of things.
Yeah, I feel like because for I know myself. Like I think you are your biggest kind of enemy and your own biggest critic in so many ways. And yes, you're right. That if I didn't have that experience, I would have totally learned everything I needed to learn in medical school. But I think my anxiety was just like, you know, you need to learn something, Rashmi. You cannot let this year to go to waste. And I think I had to do something medical related in order for me to feel like I was somewhat prepared.
Well, I think it was actually a really good idea because you could have done it and realized, I really hate this. This is not what I want to do. But it sounds like you loved it.
Yeah, I really, really enjoyed my experience. I think just like, I don't know, learning the BLS, ACLS algorithm, knowing what are the components to like helping revive someone or save someone. I think that's the core of medicine, right? Like you know, that's if someone's heart stops, like what are some of the things that you do? Okay, all right, you need to compressions, you need to do this, you need to do that. So that is something I was like, at least I have this skill, right? And I'm going into medicine because I want to save people. I want to help people. What is the best way to do this, and learning how to, you know, bring someone back to life, or, revive them in some way. So I think that was like at the crux of it. And yeah, I mean, during that year also, I decided that I was going to explore my love for the culinary arts, and I worked I
That's
worked
different.
yeah, so there's a lot of overlap between food and medicine. Overall, I think generally as a society and as a population, but even personally for me, I have a very very close connection with food and different kinds of food. So um I worked in a restaurant, and worked as a hostess, worked as a waitress. I worked as a manager, and just saw all sides of the culinary world. And
I was gonna say that I don't see that here.
yeah, it's kind of, it's hidden in my CV, kind of here. Things, over time just get like, sloughed off because there's more things I've added on. So
Yeah, and maybe potential employers at this point aren't that interested in the culinary experience that you have, although I think it kind of adds to your, your overall background and life experience. I like
definitely.
that. I'm a foodie, so I can definitely relate to that. But I want to ask you, did you always know, or maybe a better question is, when did you know in your lifetime that you wanted to be a doctor?
Oh, not until much later. I think initially, actually, I thought I was going to be a teacher because I come from a line of teachers. Like my mother's a teacher, my father was a teacher, and I just loved sharing knowledge and educating everything, anything, or anything I could possibly learn. If there was a way for me to communicate that and like teach it to others, and so they could also understand it too, that was like really exciting to me. So and then I was like, I really liked pets. I really liked animals. So I thought maybe I could become like a veterinarian or something. And then slowly, my friends were like, like you're really good in the sciences. They're like, you really have like this critical thinking skill. Like you're great with people. Like, have you considered, you know, being a doctor, or being a physician? And I make a joke because I'm South Asian, and a bunch of us admittedly are in medicine. And there's a running joke that your parents asked you to become a doctor, and that's why you're a doctor. But I actually told my mother, I was like, when I was actually thinking about becoming a doctor, I was like, I asked her, I was like, what are your thoughts about me becoming a doctor? And she was like, are you sure you don't want to become like a lawyer, an engineer, or something? And I was like, why? She's like, well, it's a very long road, and there's a lot of challenges, and all this other stuff. And I also come from a family of lawyers and engineers. So she was like, you have so many people that can give you inspiration and connections and stuff. She's like, you already have that kind of stuff. So I was like, no, I kind of want to do something different. So I just kind of I shadowed doctors just to see if I really liked it. I volunteered in the emergency room at Cornell, and I really, really liked it. I liked the kind of thinking on your feet. I liked, the appreciation, the gratitude, and the quick, patients getting better after, something that your whatever knowledge is in your noggin, like that you use that to help them. So I found that fascinating. I was like, wow, this is really, really cool. And I just, from that point on, I just kind of like took it step by step. But no, there wasn't a really big aha moment for me. I think a lot of people had an aha moment, but me, it was more like a culmination of experiences.
Was just a natural progression.
Yeah, I just felt like this is the best way I can use my ability to critically think, or and even teaching. Like I found that teaching, my love for teaching and love for sharing that knowledge, was also heavily incorporated into the field of medicine. And I knew that this was the best way I could help people and contribute to society. So
So when did you start figuring out what you wanted your specialty to be?
so for me, I feel like I'm always like late in the game. I'm always like the last one to like make a decision. And the same thing with gastroenterology. So I went into medical school thinking I was good with my hands. I was like, okay, I'll become a surgeon. And I was like, what is the coolest surgeon that you could ever be? And I was like, a neurosurgeon, right?
That's what I was just thinking. So
Exactly, right? You're like the coolest type of surgeon. I want to be that surgeon. And I mean, I did some research in the neuroscience lab at my college at Hunter. So I really liked it. I was like, this is really cool. And then slowly in medical school, I was like, actually, I kind of like the heart and I like the physiology, and I fell in love with the heart. And I wasn't really excited about the brain. I mean, it was cool, right? But I was like, the heart's really even more cool. So then I was like, you know what? I'm going to become a cardiothoracic surgeon. That's it. I'm going to do that. And then, it, and then a few years went by, and I started my surgical rotation. I was like, man, I don't like the surgical like rotation. I don't, I just didn't vibe with the environment. I didn't vibe with like the way I was thinking about the patients. And I really wanted to have like a different approach to my patients. And I was like, okay, I still like doing things with my hands. So what can I do with my hands and still think about my patients the way I want to think about them? So I fell into internal medicine. And in internal medicine, there's really like only a few routes you can take if you want to really work with your hands and do procedures. One of them is GI. The other one is interventional cardiology, which is like, takes a while to get there. And then some, pulmonary critical care. So this is all very nuanced stuff, but essentially, I really liked learning about so I'm such a physiology geek. So I knew that like I had to be something that was like more physiology based, and GI really attracted me. But really late in the game, like I didn't even know I wanted to do GI until like I was a resident. And most people know they want to do GI like in medical school because it's like so competitive and et cetera, et
but you
cetera.
knew that you wanted to play with toys and gadgets.
Pretty much, yeah. I mean, I liked playing video games. I still love playing video games. I'm really good with my hands, and I have long fingers, so I was like, okay, maybe maybe this could help someone in a meaningful way. So, and GI is really exciting. It's such a fertile ground of medicine, and we're doing so many things now that previously were done by surgeons. And I mean, offering that type of more minimally invasive um, option to patients while achieving the same type of therapy, I mean, that's pretty cool.
So when you had your first introduction to doing gastroenterology work, like playing with the gadgets, were you doing like the usual things I think we associate with GIs, endoscopies and colonoscopies? What else? What else do you do?
There's a lot, yeah. Um, uh, so as a resident, as an internal medicine resident, you normally don't do any procedures because that's I mean, gastroenterology type procedures. You can do other procedures as a resident, but the endoscopy and colonoscopy, you start getting exposure as a first year fellow. So so that was me maybe a year and a half ago. I had really touched a endoscope maybe like once or twice and played around with the dials here and there, but my first like experience was about a year and a half ago. And since and really there's only two orifices you could really go through, right? You can only go through the top or the bottom. So when we go through the top, it's called an upper endoscopy. And we also have like different tools that we can use to like diagnose lesions, take biopsies, treat bleeds. And we could do upper, we could do it through the colonoscopy as well. And really, I mean, we have a lot more, we have a surplus of types of devices that we can use to try to get into like little tiny spaces into the GI tract and do therapies and stuff. So it's actually really awesome. And I wish a lot more people knew about it, because even myself, until I really expressed a lot of interest into it, I was like, I wasn't really fully aware of like the potential of procedures and gadgets and tools and all these other, exciting new technologies. But I'm learning it slowly. I mean, I'm still learning it. I still don't know all the tools, but
So what are some of the things that, if this is such a thing, that are trending right now in your field?
um, so some of the things that are trending are so there's a few things. So one of them is, so people can have hernias. So they can have like a certain type of hernia where the stomach goes into the upper part of the chest and causes a lot of reflux and a lot of discomfort, and people, have trouble eating. And usually a hernia repair, sometimes most it's mainly done through a surgeon. In the past, typically, traditionally in the past, it's done by a surgeon. They poke holes in the stomach, and then they use that method to repair the hernia. So they take the stomach and they kind of wrap it around the esophagus just to kind of create that barrier. But in GI, we found a way to do that endoscopically. We found a way to, like, use our endoscope and use a tool where we can create a hernia repair endoscopically without doing any of these incisions. So that's one really cool thing. Um,
That sounds nice. No scars.
no scars. Yeah. And, length of stay in the hospital shorter. Patient outcomes are essentially the same. Even like long-term complications are a lot reduced compared to the surgical method. And I think having our surgical colleagues is still important, because there are cases that we're not able to do that endoscopically, and that's when they come in. But that's one of them. The other types of procedures is that we can remove pretty advanced precancerous lesions in the colon, just by using our endoscopy techniques. It's called the endoscopic submucosal dissection. It's a very fancy term, but but
Yes, it is.
but it's essentially, some of these patients, and typically in the past, they would have to have their colon resected, like that part of the colon resected, in order to remove that lesion. But we can now do it endoscopically. And obviously, it can't be cancer, like actual cancer. There are, restrictions to that, but what was traditionally done surgically, now we can do endoscopically. So that's really cool.
How would somebody get one of those hernias? Like, what causes that?
Oh, many things. I think a lot of people can just develop them over time. Some of them have like just a genetic predisposition, or like a family history of hernias. Um, Sometimes, I mean, like if you've had abdominal surgeries, it might increase the risk of like your stomach just kind of going, past the area where it's supposed to create a barrier. So there's no like hardcore risk factor as to why people develop this. They just develop them, and then you know the most important thing is that repairing these hernias is important, because if you have ongoing acid reflux, that acid exposure can really damage the cells in your esophagus, and cause like precancerous type cells, and also symptoms like, it's a quality of life thing. You want to repair something that's causing a lot of symptoms.
Well, I have acid reflux, so now naturally I think I have this. And I know there's a term for that when you hear about some medical diagnosis and you think, "Oh my god, I have that. I have all of those symptoms." Is that something that happens to med students?
You have no idea. It happens all of the time, and I think I must have tried diagnosing myself, like, with 15 different things in the first, like, 6 months of, like, medical school. So, definitely, I mean, once you hear about something, you're like, "Oh, I have this symptom. Do I have cancer?" Like, and then you, like, go down this, like, rabbit hole, and then you look up on WebMD, which is not a good resource, by the way, but you look on WebMD and you're just like, "Oh my god, I have cancer," and then, you fall into this whole thing. So,
Yeah.
yeah, it definitely happens a lot more, even to us. Like,
I would think so because I'm not always reading any kind of medical materials, right? So, but when I do, or if I'm sick or something and I, refer to Dr. Google, then that's when I see it. Like, oh my God, I have all this stuff. It's either a cold or I'm going to die.
yeah, pretty much. It's like a black hole. It's like
Yeah.
you do one thing, or then otherwise, if you don't do this, you're like here on the other side. So
Yes, and the worst is to just, have a headache or have flu-like symptoms because it seems like that could be anything.
anything. I think the beauty of medicine in general is like, yes, we hear about these symptoms, and we use like the whole picture. We use like what you're telling us, how it's happening, when is it happening, what triggers it, and then we also use the lab data, we use the images, we use everything in our power to come up with this reason why whatever is happening to you is happening to you. And this is something I also tell medical students, because I'm just like, look, you're gonna learn all of this stuff, and you're gonna for your exams, it's gonna be like, okay, if this person has X, Y, and Z, then they have this, right? But in real life, that is not the case. Like, you have patterns of like things that occur together you know in synchrony, and but they could be totally unrelated, or they could be totally related, and you don't know. But the part of the diagnostic workup is getting the test done and making sure there isn't anything serious. And if there isn't anything serious, the thing in GI that we always focus about is like, is this cancer, right? um
Mm.
and I think naturally anyone comes to a doctor if they're having a symptom. The in the way back of their mind, they're thinking, is any of this cancer, right? And I think your concerns are our concerns, and our concerns are your concerns. So it's like, um, that's the first thing we always try to rule out is cancer. But then there are functional diseases that we are apt at treating, and we use medications, we use lifestyle changes, and you know, um, yeah, that's pretty much it. I think I just went on a tangent there.
Oh no, it was a good tangent. I enjoyed it. Tangent away. So, do you ever get people that come in and go, "Well, I saw this on the internet and, I think this is what I have," or, because I get patients, I get clients all the time that will tell me, how I should handle their case based upon something that they saw on the internet, which is frustrating. Do you get that?
All the time. I mean, I think being a professional in any career, you're going to, now that we have Dr. Google, or Judge Google or something like that, you have people who are obviously are rightfully doing whatever research they can. And I think part of what separates you from the internet is that you have experience, you have accurate resources and data and stuff like that. So I try to understand, my approach usually is to try to understand what they think and why they think this, and go through the steps as to why it could be what they're thinking or not what they're thinking, or what we need to do to further evaluate to figure out what it is. And I think that kind of like working with someone rather than telling them, oh no, it's not this. Like, I almost never use like absolute
Mhm.
statements, because I think, again, like I mentioned, like nothing is perfect in medicine, nothing's perfect in the world, and it could always be something that you're concerned about, extremely rarely. But I think that's just kind of where I go about it.
So do you like the aspect of like when somebody comes in and they're kind of like a puzzle that you have to figure out, what's going on? And you get to use toys sometimes to do it.
Yes, absolutely. I think that's what also drives a lot of people to go into medicine. It's like having that challenge. Because I feel like if it was easy, I mean, if I feel like if anything in life was easy, you wouldn't appreciate what you have or how you're doing it when you're there, right?
Yeah.
I think it's more of a, um, we're trained to think this way. Our medicals, when you go into medical school, you're trained to be like, okay, look, it just because this person has this one symptom doesn't mean it's this. You have to take all this information, synthesize it, put it together, and the two same people with the same symptoms might not have the same diagnosis, which is interesting, right? Because
Yeah.
you learn through pattern recognition, you learn through all of these things, but part of the beauty of what you do and also what I do is figuring out that piece of the puzzle and figuring out that piece that where you could really help them. If you find it, then you could really help them.
What are some of the other things that you're seeing, as far as quality of life for people? Because something that I've been maybe more attuned to recently, I don't know if it's more of a thing or if I'm just noticing it more, is things like IBS. And I'm kind of wondering if that has anything to do with the quality of the food that we're eating or maybe what we have access to. Do you have any thoughts about that?
So, in terms of what we're seeing more frequently in GI is documented, at least, or there's data behind it, is we are seeing colorectal cancer more often, and we're seeing it in younger people. And, it begs the question, what changed in the last 50 years that now we're seeing it all of a sudden? Is it that we're diagnosing it more because we have the tools to diagnose it, or we have like the more specific tests? Or is it that people are just having these diseases and more people are having these diseases? So that's one thing we are seeing more frequently in terms of IBS. And I know I definitely, we talked about this earlier, but I think, it's hard to say whether it's increasing in prevalence or even incidence. But I have, so with IBS particularly, some people can be really prone to developing IBS if they have a history of, antibiotic use and they have infections after antibiotic use. And as you and I both very well know, we treat antibiotics we give antibiotics for everything these days, even though it's not, a lot of times it's not even warranted. So you can just imagine a scenario where you're giving antibiotics, you're killing off, the good gut bacteria, and you're creating a situation that's a little hostile for the GI tract. And in that situation, you can have IBS like symptoms. You can have constipation, diarrhea, abdominal pain, cramping. And I am seeing this. And the gender, there is a gender preference in IBS. There are more women and more young women with IBS. But I'm actually, anecdotally, I don't have any data about this, but anecdotally, I am seeing even young males coming to me with IBS. And what is a trigger? It's a culmination of things. There's genetic reasons why some people have IBS in their entire family, but some people have traumatic life experiences or very stressful situations, and it just something does it where it just alters the gut microbiome environment, and that's it. You throw your gut into a spiral. One of the ways I do counsel patients to improve or like reduce the risk of suffering from gut disorders is their diet. And you mentioned processed foods, what we're eating. Yeah, I agree with you. There's definitely something that's happening in these foods that the classic American diet is promoting in our gut, and it's not creating a nice environment. Like, we're not liking it at all. And
Yeah.
even the tobacco exposure and all of this stuff, I mean, it does beg the question. I mean, we have to definitely feed our gut with good whole foods, right? And that includes like fruits, veggies, fiber, and reduction of high sugar, processed. All of these things will do your gut really, really good.
What about you? How do you eat? Are you plant-based?
I'm not entirely plant-based. I am converting slowly. I mean, I do have, I like seafood a lot. So aside from seafood, I mainly eat vegetables like whole veggies. I do I do drink milk. I I do like milk, and I think that I do realize like whenever I do have like dairy products, I feel like a little bit more congested, or I feel like
Mm.
more lethargic. So that's something I'm working on cutting off, and I think it's like being a South Asian, dairy is very heavy in our diet. So I'm definitely working on that. But yeah,
Well,
um,
I like cheese.
I
It'd be
love.
hard. Yeah, you do. It would be hard for me to cut out cheese. I actually just interviewed one of your colleagues, and I think you had done some kind of podcast or something with her, Dr. Supriya Rao.
Yeah, she's amazing. We've done a few kind of IG lives together because she's an attending gastroenterologist and I'm a GI fellow, and just kind of sharing our experiences about women in medicine, women in GI. It was really she's amazing.
Yeah, I really enjoyed my conversation with her, and we did talk about nutrition and eating plant-based. And I was like, "Well, can I eat cheese?" And I don't think she really approved of the cheese, but so I thought I could ask you and maybe get a different answer.
It's a hard lifestyle to part of your lifestyle to change, and I think, I mean, there's so many good cheeses out there. I'm not gonna lie. Like, I mean, one of my favorite cheeses is Midnight Moon, and I'm not promoting cheeses here on a podcast, but
Yes.
I really like cheese. So it does. I mean, it's hard, and obviously do what is comfortable for you. You don't have to completely cut it out, because I think that kind of impacts whether you'd adhere to such a diet at all, in the future. And not even you, just like other people. Me personally, if you told me I had to cut out dairy or cheese, maybe I'd be able to do it for like a week, but then I'd go back.
Yeah. Yeah. Well, is it the kind of thing that you could just limit your intake? Or is it like, well, if you're having it at all, you're still getting the disadvantages of it. So if you're gonna eat it, you may as well indulge.
I actually don't know the answer to that question. I feel like the quantity matters, rather than just like sheer just having exposure to the, yeah, I don't know. But I do notice like people who do have like healthier lifestyles, they have better gut health than others.
Yes. Dr. Rao had recommended a documentary that she saw called Changemakers. I don't know if you've seen that. And I watched it last night, and it's about these elite athletes that are completely plant-based. And they did blood work on them, and they made all these findings how the athletes that were eating plant-based were just overall healthier and able to do more and able to recover faster. And so naturally I watched it. I'm like, that's it, I need to be plant-based. And then I woke up the next morning and I had eggs. So I'm like, well, maybe tomorrow I'll start that.
I think it's just baby steps. And that's
Yeah.
something I can tell myself. I tell my patients, like, it's whatever you're comfortable doing, and then if that's even the steps that you end up taking, and that's the end of it, then that's something. I mean, it's something, right? Like,
Yeah.
you just
Yeah. Well,
step.
yeah. But I'm wondering though, because of, even if you're not eating processed food, right? Even if you're not eating something out of a box, there's still some debate about, well, are whatever food you're getting, even if it's in the produce aisle, are there pesticides, and how have they actually grown those plants? And maybe those aren't really all that healthy either. So I don't know, what is the medical community saying about that?
Um, I think something is better than nothing in our minds. I mean, it's we. This is obviously, like, if you trust certain like fruit brands, or supermarkets or stores or local stores, like, that sell more like wholesome foods, or like wholesale foods, fruits, then that's something that you can definitely explore. But I don't know if we have like a consensus. Obviously, trying, definitely going organic rather than the non-organic option, even though it might be a little more pricey. It's hard.
Mhm.
It's something. But especially people who live in food deserts. It's really, it's like, it's easier said than done, right? Like,
Hmm.
you're asking your patients who might come from different socioeconomic backgrounds, different ideas of food, different understanding of like what's a healthy meal, and you're working backwards. So I think, um the as long as there is something, like, if you go to the supermarket and you see a green apple, just grab that. Like, the pesticides and all of that other talk, it's something that obviously is in back of our minds, but I think, like, that's what, if that's what you have, then that's better than
Yeah.
the alternative.
Yeah, it's not an argument for just, saying screw it, I'm just going to buy the Oreos instead. I mean, it's
Right.
probably still better to have the apple,
Yeah.
and take your chances with the apple. But I'm wondering, a lot of the things that you treat, are they sort of curable, if you will, with a better diet?
um so so a lot of things in GI are not curable, but they are treatable and manageable and somewhat reversible, I would say, depending on what you're looking at. So, things like IBD, like Crohn's and ulcerative colitis, these are chronic conditions. They're lifelong diseases, and you need to be on lifelong therapy. There's no like cure per se.
Hmm.
Um, but say like you had like a colon cancer and like it was early enough, that's curable because you can resect it, you can treat it with chemotherapy and be done with it. Things like cirrhosis, so like scarring down the liver, depending on the um, the stage at which you're looking at, like if it's more advanced stage cirrhosis, then likely not reversible. Just managing the complications is a lifelong chronic illness. you know is it curable? No, but it is treatable and it's partially reversible if you catch it early enough. um,
How would you catch something like that? Do you?
uh, lab testing, sometimes images really give you an idea, although not super sensitive, but a lot of the early lab markers of something like that we're on the lookout for, especially for people who have risk factors, like they drink alcohol, they have a family history, or they have known if they had hepatitis, or their liver tests are elevated. So we're always on the lookout for things and always trying to make sure that we're giving that proper advice for our patients.
Yeah, I've always wondered, if there's certain diseases, I can't remember what any of them are, where you just kind of find out that you have it, and it's the sort of thing you don't know you have until it's too late to do anything about it. I'm sort of thinking pancreatic cancer. I don't know why, if that's one of them. Um, and I always think, why don't we just all get a body scan, once a year?
And that's such a good question. And I actually asked the same question to like my professor in medical school, because I was just like, we're always so worried about cancer, right? We're always worried about all of this stuff. Like, why don't we just like scan everybody? And what happens is that sometimes, a lot of times actually, people have incidental findings, meaning like they have incidental, like, a spot here and a spot there, and like really means nothing. It means absolutely, can I curse? Just kidding.
Yes.
Jack shit. It means nothing. And that leads to unnecessary stress, unnecessary testing, and then, the spiral goes on. We live in a day and age right now that you go into emergency room and you complain of abdominal pain, you're getting a CAT scan, and that's just the reality of medicine. And it's a product of all the other issues of medicine that have come to the forefront. But you get a CAT scan, and a lot of times actually I even get referrals from ED doctors who are just like, oh, like, I saw this thickening in the esophagus, or I saw this thickening in the stomach. And like, obviously, the next step would be to take an endoscopy, like an endoscope, and take a look and make sure there isn't anything serious there. Half the time we find nothing, right? But that person underwent anesthesia, they underwent a procedure, but you can't say with certainty that there isn't, because the other half time you are finding something, right?
Yeah.
It's kind of like, shoot me if I know, shoot me if I don't, that kind of thing. I don't know if I said that correctly, but
I
damned
know
if
what you mean.
yeah, like
Yeah,
damned.
damned if you do, damned if you don't.
There it is. That's the saying.
Yes. Yeah. Yeah. It's yeah. You don't know. Hindsight is always 2020, right? I mean, you always know what the right thing to do was when you look back. All
Absolutely.
right. So I guess I'm not going to get the full body scan once a year. Um, so I want to be respectful of your time. I promised you an hour and it's been about an hour. So if can we go like a little bit longer?
Yeah, sure. Absolutely.
Thank you. So one of the things when we spoke before we actually did this interview, I told you that I wanted to talk about like if you watch television and medical shows and if you find them to just be so unrealistic, if you just cannot watch them. What's your experience with that?
I think it's a little bit of both. I'm not someone who ever watched House or Scrubs. Like those are TV shows that I didn't even know about, and like I didn't have the time to even watch TV when I was like hustling through school. But um, I've seen some of the newer ones, and I don't know. I think I have like mixed feelings about a lot of them. Um, some of my mixed feelings originate from like representation of like the doctor. And although I am seeing more representation of like people of color and like people of different genders and like, different like pronoun, I mean, like that's happening, but I still think that like some of these shows can do a little bit better at in not glorifying medicine. And I don't think a lot of what they show some of these residents doing. They have like a resident in the ED, and then they have that same resident in the OR doing a procedure, and then the same residents on the floor on the medicine floor. And I'm like, this is not reality at all.
But it's better for the storyline.
It is, and I guess it makes things more simple, just to kind of like, I guess, for people to wrap their head around it. But I think a lot of us in medicine just kind of chuckle about it. And
Yeah, well, I mean, I wouldn't know the difference, but I have the same problem when I watch legal shows because, they'll conduct a trial in a way that's not realistic and shouldn't be allowed and, it's like, stop doing that. Okay. So, I want to end our interview with a question about your reading experience. I hope I gave you a heads up on this one because I might have forgotten. Are there any books that you've read that have made a real impact on you in your lifetime?
um, I think so. Thank you for actually, giving me this question ahead of time because it made me think a little bit, but it ended up being the same answer I was going to answer anyway. It was there are these. I like poetry, and I actually like a lot of short stories and prose, and I write poetry as well in prose form. But one poet, so it's not necessarily like an author of like a fiction novel or something, but it's a poet. And her name is Rupi Kaur, and I'm sure you've seen like some of the things I've posted on my probably stories about her and her work, and she really inspires me. She has three books, uh, The Sun and Her Flowers, Milk and Honey, and then her most recent one I haven't had a chance to read. But the reason why I like her work is that it kind of speaks to me in more than just like me being a female or a doctor. I think a lot of physicians like medical books, and they like the ones that were written by surgeons or like doctors, and I think those books were great too. But she speaks about kind of like the human condition and like the role of being a woman in society, being a woman in coming from like a first generation South Asian background, and having that dichotomy between the present and the past and the future, and there's just so many elements that inspire me about her work that I um I really like reading what she puts out there. And I don't know, it's a little sometimes maybe some people might find it to be a little graphic, but me personally, I I like poetry like that, that, you know, is very direct and it's very in your face and it's very palpable. So like Maya Angelou or even Audre Lorde, those are also some of my inspirations. So as you can tell, I definitely like very strong women voices.
Mhm.
And it's, I don't know, just something that speaks to me and it kind of gets me through my day or my week. And just knowing that whatever I felt can be can be written or can be translated in that way. It was really nice.
Well, thank you for sharing that. I have seen Rupi all over Instagram, not just on your page, but all over. There's always some quote floating around. And she's also very popular at Barnes and Noble.
Yeah, she is. She is. Oh my god, I love her books. Yeah.
Well, thank you so much. I really enjoyed our talk, and I could go on, for more hours just asking you silly questions about med school and whatnot. But thank you for indulging me.
Oh, thank you for indulging me. This was really exciting as well.
Well, I really enjoy it because I did the Femme Squire series where I interviewed some incredible women attorneys, and now I'm interviewing a lot of incredible women doctors. And it's been really nice to learn about what it's like for you in a completely different profession. And you're all fabulous, just so intelligent and so passionate about what you do. And that's really inspiring.
That's so nice of you to say, but honestly, the compliment goes right back to you. I really like what you're doing here, and I really like that that your platform is very all inclusive and it's like open forum, and it's really nice just kind of having that type of conversation with someone that wants to know more about what we do and vice versa.
Well, thank you. I appreciate that. I will take the compliment. And if there's ever anything that you ever want to promote, like just awareness to a particular issue or, whatever the case may be, don't be afraid to reach out to me. And for our viewers, I will have a link in the show notes to your Instagram page. And I highly recommend that people check it out. Even if you don't have any burning desire to learn about GI issues, it's still entertaining.
Thank you.
And thank you for listening or watching, whatever the case may be. Thank you.
Thank you. And I hope this is a beautiful start to the new year. And thank you so much for having me again. And yes, I will definitely keep you in mind if I have any sort of PSAs around the corner. So
Sounds good.